All right, welcome to TIL Talks with Chris White, where we talk TILs, tumor-infiltrating lymphocytes, and all advanced cell and gene therapies, both with patients and caregivers, along with industry leaders. Let's get going. As a reminder, I am not a medical professional or medical expert. I am only a professional and expert on my story and my experience. If you are needing or seeking medical advice or assistance, please reach out to your care team. Hello, what's up? What's up? Welcome back to TIL Talks. Today I have a very special guest. I'm going to let her introduce herself. She's based out of California, Stanford University, runs the cell therapy department. Allison, can you please give yourself an introduction in the 101?
Yeah, hi everybody. Allison Betof. I am the director of the Melanoma program and the director of the solid tumor cell therapy program at Stanford. I've been a huge fan of Chris's for a long time and really excited to be here.
Right on. Thank you so much for coming on. I'm super stoked to have you on today because having doctors and the oncologists and those that are on the other side come share their perspective about not just TIL, but being on the other side of the chair, I guess, per se. And instead of just having the majority of patients and doing a lot of clinical talk. So no rules, anything goes, but it's very unique to have you on to be able to share as from the human side of things, what it's like to be on such cutting edge treatments that are evolving like that. I refer to them as curative therapies.
Yeah, it's crazy. I mean, I think it is truly, the privilege of a lifetime to work on a treatment that has the potential to truly, as you say, cure patients. And that's not a word I use lightly, but if we, look at the 10-year survival data for patients who've had a complete response to TILs from the National Cancer Institute, 96% of them are cancer-free. So, that's as close to the word cure as I'm going to come. And I think as a oncologist, and particularly as a solid tumor oncologist, that isn't a word I really thought I'd ever use. We've seen that historically with bone marrow transplants and some heme malignancies, then with CAR T cells and some heme malignancies. But if you had a diagnosis of stage 4 solid tumor until checkpoint inhibitors came around, right, we really didn't have these types of options. And then for patients who were refractory to checkpoint inhibitors, right, they didn't exist. And so, I mean, it is truly just one of the coolest things that I can imagine doing is to be able to talk to a patient about a treatment that is undoubtedly high risk, but potentially really high reward.
Yes, and I am super big upon the education and awareness factor of it because not every doctor oncologist everywhere you go is all in the know about these things. And so there's a huge portion of the population that they only discover what an advanced cell or gene therapy is by default. And that's just kind of sad. Like it's kind of ridiculous to me. There was something that came on TV the other day and it was on one of the channels you can get with rabbit ears and on primetime TV, and the story had to deal with cancer, and they're still using the word like chemotherapy, and it just blew my mind. It was like, really? Like in 2025, almost 2026, that's still like an SOC? Cell therapies, immunotherapies, clinical trials aren't at the top of those lists? It blows my mind.
Yeah, and I think even in things like melanoma, where we have an FDA-approved cell therapy, the number of patients that have never heard about it is shocking. And it's one thing not to have heard about clinical trials for new diseases and new indications, which I agree with you should be happening anyway. But for a FDA-approved standard of care medicine to not have been discussed with a patient, particularly a patient who has refractory disease.
Yeah.
We got to get the word out. We need to make sure that not only patients have heard about it, but community-based providers know to send their patients for this type of treatment.
Exactly.
And to start looking into it early.
So if a patient shows up somewhere and they're in like a rural area, for example, and the oncology setting that they're going to does not have the capabilities of an advanced, treatment center, whether it's, for the approved version, for TIL, for example, and or a clinical trial for one of these treatments, just to have the knowledge to at least refer them to one and or so then the patient should be able to access, okay, well, like, can I get access to that? And if I could, like, what would that mean? Because it's not just for melanoma, but like you said, like 90% of all cancer is solid tumors. So that's almost everything. Me growing up, especially, it was one of those things where, oh, there's never going to be a cure for cancer. And now I'm thinking, well, wait a minute. They were talking about that for many other diseases years ago. So in years from now, cancer will totally be curable and it'll be a thing. Like, where's the cell therapy center or how do I get to it?
I hope that's true. I hope that's true. And, I think the other piece is patients say too often, oh, I didn't want to ask for a second opinion or I didn't want to ask for a referral because I was afraid it was going to hurt my doctor's feelings. Like it should hurt no doctor's feelings, right? I'd like to think that I am one of the melanoma experts, and yet I send a lot of my patients to get a second opinion so they feel really good about whatever decision they make. And so if your doctor knows what they're doing and they're confident in what they're recommending to you, they should feel really very comfortable with you getting a second opinion. And if they're not, that should also tell you something, right? And so I
Absolutely.
can't encourage that to patients enough. Like, please ask for referrals, ask for second opinions. You are not hurting anyone's feelings. In fact, most of us love it when our patients get second opinions. And occasionally we learn something from one of our colleagues through doing that.
100%. You know what's super exciting for me that I've been tracking down is TIL traditionally has been for solid tumor cancers, but there are clinical trials that are going on for TIL in hematologic malignancies as well in the pediatric space. But then they're also working on CAR T, which has traditionally been for hematologics in the solid tumor space.
Yeah, so we have multiple CAR T cell trials here at Stanford, several of which that I lead for different solid tumors, places where maybe TILs aren't the right approach, or patients may have already had TILs or aren't eligible for TILs for whatever reason. TCR T cells, additionally, right? So CAR T cells has been a harder thing in solid tumor because we don't have as many great CAR T cell targets. But TCR T cells, we now have an approved TCR T cell and afami-cel for synovial sarcoma, and hopefully, more to come. We have a phase 3 randomized trial in melanoma, the SURPRAME trial with a PRAME-directed TCR T cell. That's a randomized trial, and one of the options on the control arm is TILs, right? So putting it right head-to-head against our current standard of care.
That's incredible. Now, is that as a second line of defense still? Or
Yeah, it's a post-checkpoint inhibitor trial.
okay.
And for now, I think that's actually an appropriate place for this. These are challenging treatments and they're potentially toxic treatments. And
Yeah.
I think especially in melanoma, where we know that checkpoint inhibitors are both very effective and for the most part very safe. Of course, there are toxicities to checkpoint inhibitors, but they're outpatient therapies that patients can often keep working and other things. I think cell therapy is a leap for many patients, and I think checkpoint refractory patients is right now with our current iteration of cell therapy probably the most appropriate place for it.
Right on. Something that came up in discussion with another oncologist I was speaking with who also runs clinical trials, a lot of phase 1, real big into the immunotherapy space. But he was mentioning to me, especially it is very common for a lot of adverse events, to be related to such thing as colitis to a lot of patients that are, engaging with checkpoint inhibitors and such. Now, this is what this oncologist and doctor is doing in their practice, but I wanted to kind of just throw that out there and kind of maybe get a take on it. But is it common at all for oncologists to proactively prescribe things to stay ahead of potential adverse side effects? Say, if you were to get colitis, a lot of the times you would end up getting like prednisone or steroids to combat that. So this oncologist was mentioning that, what they'll proactively do if they put them on that regimen is to give them small prescriptions to say, like, if you do start getting the symptoms and they start kicking in, this way you can kind of get a jump start ahead of it as you try to make your way into the doctor to get your appointments, because the time frame from those side effects kicking in until you're actually get into the hospital can just skyrocket. Is that?
Yeah, I think that depends on what, the access is in your clinic and your practice. I mean, we typically can get a patient in same day or within 24 hours. And so my practice is not to give patients a prescription for steroids or other
Yeah.
things because we generally know that, like, sometimes we think it's X and it's actually Y, right?
Yeah.
We've had patients that we thought had colitis, and in fact, they had a bowel infection, and steroids would be harmful and not helpful. And so I think the other piece is if you take steroids, particularly steroids, and it's not appropriate, there's the potential to harm the immunotherapy outcome. And
Yeah.
so taking it for a side effect we know is actually appropriate and does not change immunotherapy outcomes. But if we don't know that you're having an immunotherapy side effect, we have the potential to potentially harm immunotherapy outcomes. And so that isn't my practice. I do think in places, more rural centers, et cetera, where it may be harder for a patient to get in or be seen, there are times where that might be appropriate. But in a place like an academic medical center where we have a same day clinic, that's not been our practice.
That makes a lot of sense because it could do more harm than good. And it's often you have to be down to a minimum dosage or completely off once you start those to resume treatment again. And the whole point is to be fighting the disease or the cancer, not the side effects. And so,
Well, and especially, I mean, if, for example, there is an infection, not only do you have to be off to get more treatment, but you can actually make treating the infection harder if you give steroids, right? And steroids have other side effects, right? For patients, who have diabetes, they can make the blood sugar go crazy. There's lots of downstream implications of starting steroids or other immunosuppressants for our patients. And so in general, that is not my preference. But I think the flip side of that is that patients need to call, right? And I
yeah,
say this to my patients all the time. Like, you win no prizes here for suffering in silence, and I cannot
speak
fix a
up.
problem I don't know about. Right.
Yeah.
So if you are sitting at home having diarrhea, I can't fix it if you don't call me. And so we have a daytime triage service, a nighttime triage service, as does almost everybody else, to make sure that nobody's suffering in silence. And some patients always say, "Oh, I didn't want to bother you," or something else. Like, I can't fix it. This is literally my job, but I can't do it if I don't know about it.
I used to have one of my oncologists tell me to let them know 5 days, like before it happened, like just, in the
Yeah.
future, like
That
that's how much of a sense of an urgency I needed to have to let them know so they can combat it immediately, start making the calls and whatnot. So it's a
And,
huge
patients
point.
often say, "I didn't know if this was something I needed to worry about or not." And I say, "Okay, but like, I went to medical school." Right. I went to medical school to make that decision and you didn't. Right. So I'll often make the joke that, like, you pay me to do the worrying for you. Right.
Yeah.
Like, just
y-
call. We
Yeah.
have
Just
systems set up. And if we
speak
tell you
up.
it's not something we need to worry about, great.
Wanted to shift gears a little bit. There's something relating to I get asked this a lot in my DMs. People asking about to do TILs, the preparation for it, the hospital stay. I've had a lot of people tell me recently that they're able to do their lymphodepletion outpatient, which is a huge time saver both for them and their families. I'm sure it is for the BMT units. You got to, have the beds ready. Also, their cells have to be grown, QA'd, and ready to go. And this was, a commercial patient, but on the clinical trial side, is that something that's becoming more prevalent within the cell therapy units and being able to do a lot of the treatments like TILs and where you'd have to do a lymphodepleting regimen prior to receiving your cells, or you could do it outpatient?
Yeah, I think it really depends on the center and the dose of lymphodepletion. So there are many cell therapy trials right now that use a lower dose of lymphodepletion than the standard lifileucel therapy treatment.
Right.
Those can pretty easily be done outpatient, and we almost universally do that. The more standard or traditional, National Cancer Institute dosing of lymphodepletion is a little bit more complicated to do outpatient because patients often need a 24-hour Mesna pump, and that's harder to handle at home.
Yeah, I can
And
imagine.
just even managing the amount of fluids that patients need to get and keeping that fluid off with diuretics, like, those can be harder things to manage outpatient at the standard dosing, but are much easier at the lower dose because you don't have as much fluids and you don't often need the Mesna or at least continuous Mesna. And
Makes
so
sense.
for sure, this is a direction we're all moving for all the reasons you said. It's better for patients, it's better for doctors, it's better for hospitals.
Like I would just imagine this, but as the centers continue to grow and evolve, like, are the BMT units being retrofitted to be more, not necessarily like a hotel room kind of a thing, but your non-traditional, maybe a little bit more space, a little bit more comfortable of a bed to where, you know, if you're going to be staying there for multiple weeks.
I would say almost all of these are single patient rooms rather than double rooms, right? They tend to have space for family and caregivers to stay. And we try to have room for exercise bike or peddler at the bedside. And right. So all of these types of things, that's not always possible, right? And in places where space is more constrained, I mean, you know, you do what you can do. And we, of course, want to treat as many patients as we can safely treat because we don't want there to be wait lists for treatment. So, you know, I think it's highly variable, but I would say in general, yes. I mean, this has been a huge push to, you know, realize that most of these patients are going to be in the hospital, you know, a minimum a week and a half, 2 weeks. And, you know, they need to have their loved ones around them. They need to have space. They need to be able to breathe.
Yeah, because I mean, just I remember thinking like, oh, okay, I'm gonna be there for a couple of weeks. Didn't seem like no problem, but then the longer I was in there, I was just like, oh man, I got to get outside. Like, you know, you just feel confined. Like I would get real excited about walking around the halls and chit chatting with other, just any kind of interaction. But when you're within that closed space, I remember thinking like they could have made the bed a little wider. They could have made the couch by the window a little bit bigger. Like, my family would come every day, but none of them like would spend the night. You know, like there just wasn't really the space and, you know,
Yeah.
stuff
So,
like
for
that.
example, in our unit, all of the couches pull out into beds so that family can spend the night. We encourage people to bring stuff from home, pictures, paintings, whatever it is,
They
right?
they can decorate their room,
Yeah, you can't
sort of
use like
thing.
fresh flowers and things like that because of the
No
infection risk.
scents and stuff.
Within reason, like we highly encourage patients to do this. In fact, our TIL nurse coordinator, her name is Laura, has a running list of things for patients to bring from home. And it keeps getting longer because when patients get discharged, we ask them to add to the list, like what would have been nice.
Yeah,
And so things like a silk pillowcase so that if you do
they didn't
start to
slip
lose
off the bed.
that but you know, if you do start to lose your hair, it's less itchy.
Yeah,
Things like this, right? Where one of our patients taught us about, you know, the pick line shirts that unbutton around your pick
yep.
line so you can wear a regular shirt. So we just have this running list that we tell people of what to bring. And I think anything that we can do that makes this more comfortable. I always talk to patients about bringing a comfort food from home. Whatever you like to eat when you don't feel well, right? Whether it was the thing your mom made when you were little, or I don't know. For me, it's alphabet soup, which is so silly, but it's the thing that when I'm sick
Yeah.
is like the one thing that doesn't sound terrible.
Mine's the
Um,
French toast.
yeah, whatever it is, right? And if it's something that you can bring from home, bring it. Whatever can make those couple of weeks a little bit more doable.
So is there, um, are they starting to provide like little mini fridges in their rooms, or do the patients still
We don't
pretty
have
much
one
have to
in
take
the
over the
room,
nurse's
but
station?
it goes to the nurse's station, but of course is like tagged for the patient.
Okay. Because I always
There's some
felt guilty
reasons that
about,
it's harder to do this in the room, and infection risk is a real one. So that's not
I,
that easy.
I
But
always felt guilty about, you know, as soon as they came back from doing whatever it was, like, oh, well, now can I get a Sprite or a little ice cream or something? And I always felt like somebody was going back and forth. And so maybe they'll start incorporating like the little mini fridges or freezers, you know, into the
yeah, it's
rooms
hard to
or
do
closer to
because
the
it's hard
rooms.
to keep those
No.
sterile.
Yeah. Okay. That makes sense.
Yeah, so there's risks to doing this. What I would say though is the same as not calling our clinic. And patients are worried about bothering us. Like
Yeah.
the
It's
inpatient nurses,
okay.
especially the inpatient nurses on
Oh,
these
they're the
units, like
best.
they're the
They are
best.
the best. Oh
If there
my
is
God.
anything that they can do that will make your life easier, better, whatever, they are going to do it. So I would just tell patients, like, I understand that sentiment. I've been hospitalized before and didn't want to bother the nurses, but you're not. They really do want to make this as pleasant as maybe not the right word, but you know, at least unpleasant as they can for you.
I've been to multiple oncology settings, and where I did my TIL, the oncology nurses that were there for the 13 days, 12 nights made the world of difference for me and my family. Like, go to Chick-fil-A and bring in that fruit tray for the nurses and do it like around shift change. So that way everybody can get some. And like the little things made the biggest difference. And man, they just really set the bar for bedside manner and just my entire experience around that. Like I was feeling guilty about continually asking them for like warm blankets during like the IL-2 side effects. And so I started to tell people, if you can, bring in an actual heated blanket that plugs in the wall. Like, is that something y'all allow, or is that not allowed? Or
I actually am not sure. That one I'd have to check on.
some places might
Blankets,
do
I'm
it,
not
some
sure.
maybe don't.
Yeah, I don't, that's for patients, ask your team. It's a great question. That's one I'm going to bring back to Laura and ask her if our patients can do.
It was especially because I did all 6 doses of my IL-2, and I had Rigers for every single one of
For
them,
sure.
and I felt like I was freezing, but I was running a fever, but I was constantly asking for more warm blankets. As soon as they brought me one, I was almost ready for another, and just didn't seem like there was enough. And I also was starting to make a list of things that people are asking me about, and so I put it on there, like, get full-size heated blankets, like heating pads, but blankets, plug them into the wall. But of course, you got to double check with your
Double
unit
check
to
with the
see
units
if they're
and
gonna allow that or not. I
yeah.
mean, it just depends on where you're at. But long extension cords for your cell phone charger or iPad, you get really bored in there. So another thing, I had my port on this side of my body, but when I got admitted, they put a PICC line in and they gave me the choice of which side to put it on. And knowing what I know now, I would have had it on the same side as my port because it was on my right arm, my port was on my left arm. So if I was laying down and I had to rotate for any reason, I was trying to lay down, it would yank on the line. And so I was like, why did they give me an option? I would have just said, hey, if you already have a port on one side of your body, get all your lines on that side of the body. That way they're not crisscrossing. I don't know how standard that would be for admitting
Yeah,
patients.
every patient's a little different, right? The anatomy, if they've ever had a clot, et cetera. So, I mean, I think, but these are the important things, right? People say all the time, oh, that felt like a stupid question I didn't want to ask. And most of the time, they're really good questions. Just ask your team, right? There is no question that is too stupid here. I can guarantee that.
I gotcha. I gotcha. Another thing that hits my plate a lot is I get asked, is it standard when you're doing commercial TIL to be admitted to the ICU when you're doing your IL-2s? Or
Yeah,
is
every
that
center
just
is
in
different.
case?
Yeah, every center is different. We do not do that.
Okay.
And I would say many of the higher volume centers do not do that.
That's just a just in case they need to option, which they make you sign for in case you need
Sure.
to.
And I
Okay.
mean, that would be true if you were having a surgery. That would be true if you're
Yeah.
doing anything else, right? Anything can always happen. But I think
It's not heard no
it's not
matter
standard.
what.
Now, some
Okay.
centers do preventatively put patients in the ICU prior to the IL-2. I would say that's becoming less and less common. And I think as we've learned more about how to give IL-2 safely and have come out with more standardized guidelines about IL-2, should not really be necessary for the majority of patients. But of course, like a hospital should not be giving this treatment if they don't have the ability to take a patient to the ICU urgently.
Right, but it's just I get asked that now. I was always told if I needed to go, I would have the capability to go, but it wasn't like no matter what. When this time comes, we're gonna be
Yeah,
in
yeah,
the ICU. So that was
yeah.
just something I wanted to ask. On the medical side, sort of thing, as a doctor and an oncologist, are there support programs in place for y'all as physicians to help y'all with life as being an oncologist and doing a lot of these treatments? Because I mean, I can only imagine. I mean, it's got to be a very tough thing to go through to be treating a lot of these patients with these new novel things that are these one-time treatments. They're very tough. Not everybody makes it, but I'm always thinking of all the oncologists that are at the front lines, a sense, and just want to make sure and just ask, like, the programs that are in place, people being supportive.
Yeah, I mean, I think first and foremost, we are each other's best support system, both for, hey, I need help managing this clinical situation that arose suddenly. And most of the doctors who are giving TILs around the country sort of have each other on speed dial of, hey, this crazy thing happened, who's seen this before and what would you do? But also I think to your point, the emotional support of this is hard and it's hard for patients and I will never downplay that. But to your point, it's tough on doctors.
There's got
And
to be a peer connect for each other, for y'all. You know what I
yeah,
mean?
And it happens sort of organically. I wouldn't say there's a, you know,
Nothing official. Okay.
a dedicated official program. There are certain groups like AIM at Melanoma has coordinated a Women in Melanoma conference every summer, and many of us have become sort of a very close-knit support system. But I think everyone has developed their own, but it's super important. And, you know, I think patients sometimes don't realize how attached we get to them. You know, they get attached
Yeah.
to us, but we get attached to them too. And when things don't go the way we want them to, of course, it's always harder on the patient and their family, but we also take this pretty hard. And so I think that's really important.
Yeah. I definitely wanted to highlight that. It's one of those things where, you know, if you can't take care of yourself, you can't help anybody else. And that's why when the oxygen mask drops in the plane, you got to put it on yourself first, so then you can put it on the person next to you. And so, like I said, like on the front lines, we're all at war here, and you're only going to be as good as your best self. And so that's just, I'm always thinking about that. I think about all the oncologists and the doctors that I've worked with and that have taken care of me over time, especially, like I said, the nurses. It's critically important. I'm always thinking of them. Just wish I knew and remembered all of their names from all the different settings and stuff, and I could get in touch with them now. But I
Well,
mean,
what I would
wow.
say to anyone who's listening to this is, first of all, thank you for even recognizing that. But also, I mean, the kindest gift that you can give to your medical team is to either drop them a note, or if you're in the neighborhood, come visit, right? I mean, and especially patients who've been through TILs or cell therapy, like you see us, you see your outpatient oncologist, but swing by the inpatient unit someday when you're visiting your doctor. Those nurses poured their like heart, lives, and souls into making that 2 weeks a little more comfortable for you. And they very rarely get the follow up of seeing somebody doing well. And so every time I've had a patient swing by the unit, I just get so many texts from the nurses. It's so amazing. They're doing so great. And
That's awesome.
wow, you know, so I
I'm so
just like
glad to hear
that is
that.
such a kindness that patients can do to the medical team as well.
That's just a blessing, you know what I mean? Like, I had went back to my old BMT unit, you know, to go visit, and a lot of my nurses have gone elsewhere then, and it was just like, "Oh." Well, if you talk to them or connect with them, please give them my regards. Here's my contact info. Like, next
But
time
even
I
for
come,
the
I'll stop
newer
by.
nurses to see someone like you that's years out now, you know, if they have a patient next week that is getting TILs for the first time and they're having a hard time about it, you know, they can say, look, like this guy just came by and he's years out, NED, doing great. And he just came by to say hi and like wave hello, you know?
Absolutely.
And also, you know, I think for the nurses too, or the whole inpatient team, just the reminder that patients do well long term, even if they weren't your nurse, your doctor, your whatever. That we have these good long term outcomes. It just kind of helps keep the fight going, right?
Yeah, and I'm always saying this, it's the faster you can get to a cell therapy and you don't have, you know, T-cell exhaustion, the more you're gonna preserve the quality of life, or at least that's been my experience and those that I've connected with, rather than getting to it later. I'd say I'm the exception, not necessarily the rule, but those that are getting it sooner right now are showing a very durable response, and those are very positive outcomes, and that's huge because it's not just for melanoma, but for multiple cancers, and not just in the States, but globally. So it's incredibly awesome to be able to, you know, pick your brain just a little bit on this. And then I will see you in February,
You
correct?
will see me in February. I'll see you there.
So I'm gonna bring this microphone here that connects into my phone and can do in person little mini TIL talks. And so
Love it.
hopefully we can get some little recordings in during then. So I'm super excited for I need to book my travel, by the way.
Same.
So I'm gonna get on top of that. But I know that you had mentioned that you have got to jump off here pretty quickly. So once again, I just wanted to thank you so much, Allison, for coming on here, and like so many others before. I'm proud to be able to call you Allison instead of calling you Dr. Betof Warner or Dr. First, or using doctor instead calling you Allison. So thank you so much for coming on
My
TIL
pleasure.
Talks.
Thanks
And
so much
again,
for having me, and keep up the good work.
absolutely, I appreciate it. And thank everybody for tuning in, and catch you later. Peace. All right, that concludes today's episode of TIL Talks with Chris White, as we talk TILs, tumor infiltrating lymphocytes, and all advanced cell and gene therapies. As a reminder, I am not a medical professional or medical expert. I am only a professional and expert on my story and my experience. If you are needing or seeking medical advice or assistance, please reach out to your care team. I'd like to thank my guest today for joining me on TIL Talks. To our listeners who have not yet done so already, please follow, comment, subscribe, share, and smash that like button. For more information about TIL Talks and related resources, please visit www.tiltalks.com. I'm Chris White. As always, sending love to everybody. Peace.